How many of you are third year DNB? When are you appearing, that kind of thing? That's only 2-3 people. Majority are what? Second year? How many second years? Only one. So the majority are first years. Or most have finished. Or DNB, MD, or same thing. How many are? Why don't you want to raise your hand? Acha, got it.
Dinesh, shuru kare. Good evening, friends. We welcome you to Mumbai for another one of the PG webcasts, which is a part of the IAP Presidential Action Plan, and which has been very generously supported by a grant from Wockhardt Vaccines. Today's clinic will focus on neurology, and we have Dr. Rajesh Udani, who is going to be our expert today. Let's begin with our cases.
Good evening, friends. My patient, 2.5-year-old female child, Mrunal, was by birth order born of non-consanguineous marriage, Hindu by religion, Maratha by community, residing at Chembur, hailing from Satara, informant being mother, came with complaints of developmental delay since birth. Since birth, mother has noticed that her child has not achieved smiling, head holding, rolling over as compared to other children. Simultaneously, above milestones achieved by the child very late, by around 1.5 years. Now she is complaining that her child is not able to sit, stand or walk like other children and can speak only few words. So her developmental history I am going to discuss in detail now. According to mother, that child has achieved head holding at 6 months of his age, rolling over at around 14 months, and recently, that is 30 months of his age, child is attempting for crawling. That mother is telling he is just drag himself only few steps. And according to regarding fine motor,
what are the milestones you asked for in gross motor?
Sir, I have asked for the neck holding.
Correct.
Rolling over.
Okay.
And then sitting.
Sitting.
Sitting without support.
So sitting with support, sitting without
she
support.
She has not achieved yet, sir.
I see. And she's achieved crawling.
Yeah. She attempts for crawling a few steps, as per mother said.
I see. But what do you think? And with that
she
historical, if you've not achieved sitting, if you've not achieved, you think you can achieve crawling?
No.
So let me ask you, what is crawling and what is creeping?
Crawling is, child is, abdomen is on the ground and drag himself further.
Sure.
Creeping is, abdomen is off
the other way around. So creeping is like a soldier. A soldier moving forward to hide himself from the enemy. He crawls he creeps on his stomach. So that's what is achieved. Yes, crawling is difficult unless you have. Okay.
But still, to achieve creeping, she has to achieve sitting before.
Not necessarily, because she's on her tummy. She's prone. She can turn. So little bit of movement can occur.
Development quotient for gross motor was around 30 to 35%, and for fine motor,
how is it 30-35%?
So
she's 2.5.
30 months old.
30 months. And what level do you put her at?
6 to 7 months at least.
What do you achieve at 6 to 7 months?
Creeping.
Sitting. So when do you sit?
6 months with support.
Okay, what support?
With child keeping his hand in front and sits.
So what's that called? Is anterior support.
Anterior support.
And what is after that?
Lateral support.
Lateral support. So what is that called? Propping. Lateral propping, anterior propping. Correct? So lateral propping has to come, and then after that, what is the next step in sitting? So first you're sitting with support, you fall often, this, that, about 5 months, 5.5, 6 months. Maybe 6 months will be outer limit. By 7 months you're sitting well with both your hands. What comes next in sitting? Sorry? Somebody said it over here. क्या हुआ? बंद हो गया. What is pivoting? Anybody can tell? She's already past her MD, so anybody can say pivoting? What is pivoting?
Turning its trunk.
So while sitting, you're right. Just tell us. No?
Turning it towards source of the sound.
No.
The whole of the trunk.
Pivoting is when you turn around while you're sitting to get an object or whatever it is. And then comes what you thought this child had achieved, and that is crawling. Okay? So crawling comes later. It's true, it has to go in this sequence. If you don't go in the sequence, it becomes a little problematic. Okay.
And in case of fine motor, child is holding object when kept on his hand. There is no reach out for the object, and the developmental question for that.
You are saying that the child is holding if given.
If given.
Correct, that's the term. And what is he not doing? He is not reaching out.
There is no reaching out for the object.
Okay, so now let's go through this again. Fine motor. What is the earliest fine motor? What do you see?
He keeps his hands open intermittently.
Okay, so at what age is that? So before that they are closed, right?
Yes, they are
Fisted. Correct?
around 1 month intermittently opens.
And what is the reason for the fisting? Is it reflex or is it a non-reflex?
It's a reflex.
Okay, so it's a palmar grasp, right? First 1 or 2 months. Then?
Intermittently opens his hands.
At 3 months, then?
Then keeps hands open, and then ulnar grasp comes.
Now what about reaching out?
Comes around 4 months.
So what is the first reaching out type? Suppose you have to show it.
Show bright objects and
Bidextrous. So that means both hands.
both hands.
And then you need dexterous, and then of course you know all the different grasps and all that, which I won't go into. Okay.
So there is no reach out for the objects child has yet developed. In case of language, child can speak only few words, that to 3 words with
So 1 minute, the gross motor quotient is how much?
30 to 35%.
No, it's not, forget the percentage. What is the age you think this child has achieved? He's achieved head control, he's achieved turning. So, he's not achieved sitting with support. So,
5 months.
4 months.
Okay.
4.5 months. 5 months maybe. What is grasping age?
It's
Grasping is fine motor age.
4 months.
4 months. So, it's perfectly aligned. Correct? Next.
In case of language, according to mother, child can speak only 3 words with meaning.
Wow. Okay.
And that she has achieved around 1.5 years of her age.
So what kind of words does she speak?
She can speak I, ghe, bhur.
So she uses it meaningfully.
Yes, she uses. For mother only she says I to lift her up.
Well, that's okay. You might say I for father also. That's okay. In the beginning, 1.5 years, we might mix up, who's father, who's mother. But it's like a calling out. But you're saying it's meaning. So how will you check that? Because I tell you one thing. One of the problems with parents is they sometimes overestimate. Of course. So
Especially speech especially they tend to...
They sort of, they're not experts in development, so obviously they hear some sounds, they interpret them as, I or whatever. So how do you confirm?
When mother comes in front of the baby and then child says I to mother only, then
No,
and smile.
I'm saying how do you confirm from the history? So what should she have achieved if she can speak I, they and all?
Recognizes mother.
But recognizes mother is really very early, very social kind of thing. It's not really language.
So in speech and language, what before that?
Okay, bisyllable.
No, you're not getting what I mean. Anybody can tell me? What happens first? No. Language is not... What are the types of language? So what is first? Receptive is always first. So what is the first?
Please use the mic. Please use the mic to speak and don't speak together. Raise your hands and speak.
Yeah, do that. Yeah.
So vowels come first.
What is that? Is that receptive language or is it expressive language? Expressive language. So let's speak very clear. Expressive is expressive. Receptive is understanding. So what is the first thing you understand? What is the first? It's making some noise. The first receptive language milestone which is commonly understood by the parents. So don't go into the Denver and give me all those details. Just tell me what is commonly you ask the parent. Anybody?
If called by name or if the baby responds. Like
Correct. So understanding name. When does that happen?
1 year around.
So that's a sort of mistake. Okay? 4-5 months is very often that's the time when they understand their name. Okay, maybe a month later, maybe a month earlier. It definitely doesn't occur at 3 months. I've seen many children do it, many infants do it at 4 months, 5 months. So that is the time, the first. Then what's the next milestone? So does she know her name?
According to her, she responds to the name.
She responds to the name. So she's achieved that. Second? Specifically no, is it? No. Anything else? Language-wise? Receptive language.
Shows likes, dislikes.
Is that language?
Social.
Language is understanding things, what you're told to. So the next thing is, give this to Papa, give this to Mama, where is fan, where is light? That comes around what age? No, a little earlier. So around 10 months would be the average. Okay? So she knows that, I'm assuming, because you're saying expressive. You haven't asked?
I did.
Okay, so if you haven't asked, we have to ask them. Because if that is not achieved, then it's very strange that she can speak 3 words. I, they and all that. So, the question is it just meaningless babbling? When does meaningless babbling come? What's it? Tell me the expressive language now.
Would no come much earlier?
Probably yes.
No.
Probably yes. Because, and it also, the problem is, it's very difficult because whenever you are asking, no, baby responds to the face much earlier. So the word no, very often the parents will ask them, वो ना समझता है? हाँ समझता है, वो मैं बोलती हूँ तो रोने लगता है. So that may be a response to the face, because the facial expression is very early. 5-6 month old baby can easily respond to that. It's the same way with when you're talking about objects. पंखा को देखते हैं ना? अच्छा पंखा को देखते हैं, कैसे देखते हैं? वो ऊपर देखता है, वो जो घूम रहा है ना वो देख रहा है. नहीं, आप पूछते हैं कि पंखा कहाँ है तो ऊपर देखता है, वो नहीं कर रहा है. So the difference is there. He is seeing the visual thing, he is attracted by the spinning or whatever, but he doesn't know the word fan, or doesn't know the word mama, or doesn't know the word papa. That has to come before he can say I. That's a very important milestone you must ask. The first year this is there. Of course there are many other milestones after the first year, but this is important. So we'll ask that. Anything else? Now social you were going to tell me. So language, according to her, expressive language is 1.5 years. By the way, when is meaningless? What is the expressive language development? So let's not talk about, like I said, not from the books, but how do you understand? This I've mentioned many times.
Yeah. Come on, expressive language.
Somebody has
which you are wanting
probably
to answer.
heard from me also.
So what's the first thing that the baby does in expressing language?
Cooing comes first.
Okay.
Followed by monosyllables.
Oh.
Vowels first.
Vowels. So what is that? Where does the vowels come from? Front of the throat or back of the throat?
Anterior vocalization.
Do it now.
Posterior vocalization.
So posterior vocalization. That's where A, E, O, U. Everything from the back of the throat. And when do the anterior vocalization of consonants start?
That's by 6 months.
7 around.
Monosyllables.
So basically consonants. And which consonants? You're doing well, so.
Ma, ba.
What are those called? Lip. Ma. Ba.
Labial consonants.
Labial consonants. Lip.
Yeah.
And that's why you have mama, papa, dada, or all those. Every language has the same thing. Baba. Because these words are common in everybody's. The first consonants you talk are these. So in different languages, you have similar sounding words for mama and papa. Because they're universal, all over the world. Okay. Now, after that, the meaningful monosyllables. When do they come?
After 1 year.
Yeah. So 12 months onwards. So over here you have 3 words, which means she has reached expressive language 12 months. So she must be receptive language at that age also. What about social?
She just recognizes mother and smiles, but she has not achieved stranger anxiety yet.
So that's again odd, no? I mean, you have this kid who's knowing I and all that, but has no stranger anxiety. When does stranger anxiety come?
7 months.
It's a little variable. And what does it depend on? The number of people looking after the baby. Have you ever gone to seen an orphan kid? I mean, the one who's in the, orphanage. They don't have much of stranger anxiety. I mean, they do have with their one, but they keep changing people to look after them. Or your joint family, lot of people in the house. Everybody is taking and all that. So itna anxiety nahi hota hai. If you go to a nuclear family, especially from 3 people, father is gone, even the father ko jayega nahi wo. Because he's only used to the mama. And that comes around, it depends, I've seen as early as 5 months and as, 8-9 months. So that's a little variable. But stranger anxiety is not there in this case. And that's a little odd again. Okay, what's the last thing?
Social.
So you are saying social is around smiling and recognizing, say about 3-4 months? So really you have everything in 3-4 months, 4-5 months, that below 6 months, but your language is a little advanced. Correct? So that's a little odd. So let's confirm that. Anything else in the history?
This is the developmental part.
No, anything else?
Yes. There is a history of seizures mother is giving since birth, and it was there during her NICU stay, in which mother has not witnessed the seizures. Similar paroxysmal activity mother has noticed at 2 years of baby's
So
age.
either when you say seizures, you are giving your interpretation. What should you say?
Paroxysmal activity.
Either event, paroxysmal events. So besides seizures, what are the other paroxysmal events which occur in infancy? Tell me some of them. Not all. In infants, one is of course seizures.
Breath holding spasms, tics.
Absolutely. So breath holding spells. Breath holding, what do you say?
Spells, sorry.
Don't use the word fits. So breath holding spells. What are they?
At the end of the crying.
No. What are they? What is the reason why you get breath holding spells? In the sense, what is the pathophysiology?
Anemia is considered to be.
Pathophysiology. It's a type of syncope. It's a type of syncope. So it's, essentially something where you get a drop in your pressure, you get asystole and all those kind of things, you get slowing of your heart rate, and you get circulation to your brain reduces and you become unconscious. You may even have a little convulsion at that time. But that's called not called epileptic seizure, it's called an anoxic seizure. So that's different. Anything else?
Tics.
Tics coming in the first year is a little odd.
Yeah, and any other things in the first year?
Myoclonus is a type of seizure, no? Also.
Benign sleep myoclonus.
Okay, so sleep myoclonus. Absolutely right. When does it come?
So when the baby just...
So
wakes up
neonatal
from-
period. Usually newborn period. May go on for a couple of months, but usually disappears after that. So in sleep you get movements which look like seizures. So all these are seizure mimics. Now, just if you tell me this patient had seizures, that's a little odd. What is the most common seizure mimic in the newborn period?
Jitteriness. Jitteriness.
Jitteriness. What is jitteriness? What type of movement is it? Tremor. Absolutely correct. So it's a movement disorder. It's a tremor. It's rhythmic. It's equal on both sides. It's not in seizures. What is a typical clonic seizure? Anybody can tell me how do you differentiate? If you see a seizure or a jitteriness, how do you differentiate it? Just looking at it.
It's rhythmic. Startle.
Yeah, absolutely. So startle, usually startle is one time. If startle keeps occurring, then what do you call it? Excessive startle or hypereplexia. That again occurs in the newborn period. So normally you have one startle, maybe two, and then you habituate. But if it persists, especially in the newborn period, you can do this and you get, jerks. And the third thing I was talking about, jitteriness. So if you look at it, tremors are equal movement in both. So both movements are like rhythmic, while there's no fast and slow component. While clonic is a fast component, slow relaxation. So when you see something, you should make a differentiation between these two. Okay. Especially in newborn period, seizures are diagnosed by doctors, nurses, and it becomes a chappa. Then he had seizures. So it becomes a problem. So over here,
What about shuddering attacks?
Yeah, many. I mean, we can go into that.
Sorry.
Shuddering attacks are basically what anybody can tell me. When do they come? Tell us.
Generally, if someone is throwing a tantrum or at that age or something you're unhappy with.
Not tantrum. Usually happens when they're excited or when they are a little angry, but they don't cry and all this. So, they shudder. This is a shudder. Okay, it happens in normal infants, usually after 6 months, when they are playing and all that. They can be easily distracted. So shuddering also another thing which looks like one of the spasms or myoclonus or something like that. So there are many different non-epileptic attacks. So whenever you always talk about events. And then in your history, if you think there are seizures, you have to justify why do you think there are seizures. Okay? So this patient, tell us what happened, newborn period.
Taken birth history. I'm just describing the paroxysmal activity. I'll go in detail with
No, so tell me about okay, you're giving data. Okay, tell us the paroxysmal activity.
Paroxysmal event was in the early morning while the child was sleeping in the form of twitching of face with uprolling of eyeballs and tightening of upper limbs and lower limbs, lasting for 15 to 20 minutes and subsided with IV medication.
When was that?
At 2 years of her age. And the child was admitted for 2 days for that. And got
But is there anything else you want to tell us?
There was no any history of fever or the history suggested of hypoglycemia or dyselectrolytemia during that period.
What is the history of hypoglycemia and dyselectrolytemia?
They can precipitate seizures.
No, what is the history?
Whether child
You are
has
saying there is no history suggestive
there
of.
is no history of any loose motions or child has not.
See, you don't have to come to the diagnosis of why the seizure occurred. All you can say over here, there's a very obvious reason why the seizure occurred. I mean, seizures are many times more common in which population? And in children, but which type of children? Delayed children. So you have to search for the cause over here. You have a delay, obviously you have a brain issue, and these children with delay often have seizures. So fine. Now tell me, in that particular thing which you described very well, why do you think they have seizures?
There was uprolling of eyeballs and tightening of, and which was.
So what are the characteristics of seizures versus other things which make you move more towards seizures? So tell me the 1, 2, 3, 4. So uprolling of eyes can occur with many things. There's some in syncopal episodes you can get uprolling of the eyes. In patients with there's something called paroxysmal tonic upgaze of infancy. There's something called oculogyric crisis in infancy. So all these things can have uprolling of the eyes. That doesn't mean necessarily seizures. What are the important characteristics of seizures? No.
Can't be restrained, sir. You can't restrain the movement. If you try to...
No. First of all, you're assuming all seizures are movements. They are not. They are convulsive seizures and they are non-convulsive seizures. So non-convulsive seizures, you may have an absence seizure, you may have a complex partial seizure, you may have a convulsive seizure, could be a focal motor seizure, could be a generalized tonic-clonic seizure, so there are many things. So over here, the most important thing is unresponsiveness. That is the most important. So that has to come from your history. So in that 20 minutes when he was having, the mom was calling her, was hitting her, what was happening? Was she responding or was she not responding? Was she responding?
No.
You sure I asked?
It was a status like she was not responding.
No, you asked or just assumed? That's important. Second thing is, anybody else? Most seizures have eyes open. Even newborns. So newborns with seizures are unresponsive, eyes are open. So they look awake. And therefore the child's mother and father may think that he's awake. He's not unconscious. When you ask them, बेहोश था? नहीं, बेहोश नहीं था, आँख खुली थी. अरे आँख खुली थी, लेकिन response दे नहीं रहा था. That is an important. These are the two things in children and infants which help you differentiate seizures from other things. Okay, go on.
And the third episode occurred at 2.5 years of his age, and the event was similar only, but lasted for only 5 minutes and subsided on its own. And it could be a part of remote symptomatic epilepsy. Let's
not go into the diagnosis now. I'm going to ask you to summarize from your history what do you think is happening. But you haven't come to the end of your history now. You're going to give me the birth history. So tell us that.
As there is a significant birth history. At 23 years of mother's age, she has spontaneously conceived, and ANC registration was done at first month of pregnancy. Mother was on regular follow-up and received hematinics and 2 injections. Weight gain of mother was around 4 kg. First USG done at 5th month of pregnancy, which was told to be normal. There was no history of any fever with rash, headache or signs of pregnancy-induced hypertension or any other major medical illness in the mother.
Too much in detail. Go a little fast.
There is no history of any decreased fetal movement. It was a preterm delivery. Around 7th month of pregnancy, mother had history of leaking PV, which was of around 12 hours and which was a preterm vaginal delivery. Baby not cried immediately after birth, and she required resuscitation and immediately transferred to the PICU. And on the same day only, child was put on ventilator. And child was on ventilator for around 8 to 10 days, and during that period, child had 1 episode of convulsion for which mother has not witnessed, and mother is also giving history of PRC transfusion during NICU stay along with IV antibiotics. Child was there on ventilator for around 8 to 10 days, and slowly child was weaned from the ventilator. And
fine. So she had a problem at birth. Now tell me, in a newborn, when you have a history of a neonatal seizure, and believe me, most of the times the parents are just told. Sometimes they're not told also. They just check the discharge card, somebody has mentioned. So how do you decide? In this case, of course, she had a ventilator and all this, so hajar things are there. But if suppose there was only a history of a neonatal seizure, how do you decide what type of seizure was it? So what is the first important historical question which should come to the fore?
Which day of life?
Very good. Which day of life? Very good. That helps you the etiology. Second? So day of life, tell us which are the days of life where it occurs.
Hypoglycemia coming at day 1.
Day 2.
No. Hypoxia coming at day 1.
So HIE.
Then
perinatal asphyxia day 1. Okay.
Day 2 hypocalcemia.
No, so day 2 and 3 hypoglycemia. Okay, hypocalcemia doesn't come so early usually. Third is, suppose after a week.
Due to
So I just give me the first important one at day 1, day 2, 3 and day 7.
Day 1 is hypoxic, perinatal asphyxia.
So perinatal asphyxia.
2, 3 is
Don't use the word hypoxic because there's an element of ischemia also. Hypoxia is oxygen come ho gaya, ischemia is when circulation is a problem. So both have to be there to call it. Okay, second.
Day 2, 3 is due to hypoglycemia or
And
calcemia.
third is day 7.
Brain
Day 7. Meningitis, sepsis, meningitis essential. Okay. Then of course there are many causes, I'm sure you know all of them. Then how do you decide? What is the second question which is important? Okay, Rahul. There's one more Rahul over here. Bolo. What is the second important question? Second important, how do you decide the etiology of something?
The baby was feeding well or not?
So presence of neonatal encephalopathy, which is evidenced by feeding, evidenced by lethargy, evidenced by seizures. So seizures with encephalopathy as opposed to seizures without encephalopathy. So what are the seizures with encephalopathy? Almost all. So HIE, there's encephalopathy. Hypoglycemia, there's encephalopathy preceding the seizures. Kernicterus rarely gives rise to seizures, but can, again there's encephalopathy. Meningitis, encephalopathy. Hemorrhage, encephalopathy. All that precedes the seizures. The seizures is usually the last thing which happens. In case of seizures without encephalopathy, what are the common reasons? This is much less common.
Metabolic.
Which metabolic? Hypocalcemia, absolutely. Usually earlier hypocalcemia is not common, late onset is common in cow's milk and all that. So there is hypocalcemia. Anything else? And hyponatremia and all that have encephalopathy.
Anatomic defects like
Correct. So if you have epilepsy already, that's what I'm trying to say. So newborn who has a structural lesion in the brain, before birth, has got a torch infection, has damaged his brain, say at 6 months of pregnancy, or if you have a patient maybe who's got, something which is not, is epilepsy. There are many epileptic encephalitis, we won't go into details of that, but they come with seizures without encephalopathy. So keep feeding, they keep having seizures. And the reason, what is the difference between the first group, what are they called? The ones who are having seizures with encephalopathy, what are they called? What type of seizures? Acute symptomatic seizures, absolutely correct. What does that mean? How is it different from a epileptic seizure?
Secondary to a cause. Basically.
Why hypoglycemia is a cause of seizures? So why don't you call it epilepsy? Hypoglycemia is not organic. Very
symptomatic.
Symptomatic, acute symptomatic seizures. Any of us who has any of those problems can get a seizure. That means it is because of an acute brain insult which gives rise to a seizure. And that's called acute symptomatic seizure. Epilepsy, on the other hand, there is a change in the brain circuitry which is responsible for a tendency to get seizures. That takes time to develop. So if you have a patient of hypoglycemia at birth, he might develop epilepsy at 6 months or 12 months or 3 years or 2 years, whenever this fellow developed. You understand? So it takes time. While if you have a patient who already has epilepsy before birth, the tendency is there because of brain malformations or something of that sort, that will be seen at the newborn period. So the neonatal epilepsies are different from the neonatal acute symptomatic seizures. This is a very important concept and you must get this. So 90% of acute seizures in the newborn period are symptomatic. Maybe less than 10% are epileptic. You understand? Epilepsy means, they will have recurrent unprovoked seizures. Okay. Shall we get the kid in?
Yes, sir.
Shall we get the child in?
Yes, sir.
you have any questions, please answer.
So regarding that child responding to the word no, even if there is a facial expression
Please
change
speak in the mic and speak loudly.
so even if there is a change in facial expression of the parent or of the mother, still if the child is recognizing that, that should also be a component of receptive speech only, isn't?
Suppose you have a deaf child. Does he respond to the facial expression?
Yes.
He does. He may not hear the word no, but you might usually, when you say no, no, your face changes.
Receptive.
So usually language, understanding language means understanding words. It doesn't mean understanding expressions. Expressions are what is called the social network. So what is a social network? Now that you started me, I'll tell you. For example, I meet Hemant. My first thing is face perception. So I look at him, in the back of the brain, I understand that he's in the face. Then I have to recognize who he is. It's called recognizing of the face. Then there's something called recognizing his facial expression. Oh, he looks sad. Okay, if he looks sad, then I then make a response. Hemant, what's wrong? This is a social network. Now the language network is completely different. You understand things by hearing words. Okay, so somebody says something, I have to understand that word comes to me only as a sound. That is in my temporal lobe. I just hear it initially as a sound. Then in the temporal lobe, the secondary auditory area understands what is said. So the name Hemant. Then I have to delve into my verbal memory and find out Hemant kaun hai? Then I have to put an image to him. Then he asks me a question which I have understood. Then I search for the right words to respond, which goes to the Broca's area, and finally that's the language network. Of course, they are totally related. They are related. They come together. So you don't speak like a robot. You speak with body language. You speak with expressions, and this is which condition is the most where the language network and the social network are not, are completely out of whack. And what is that? Come on, autism. So all these long distance networks where you perceive the face over here but respond from the front. So they have to have connections. Or if you have understanding language from the back on the left side, and you have to have connections in the front to speak. So reception, transmission, expression, all that requires networking. What is autism? It is a network problem. It's called connectivity problem. It can happen because of various reasons. It may happen because of genetics, which is the most common. It may happen because of epilepsy. So you have spasms, infantile spasms. The most common thing you get is epilepsy, autism. Or it may happen because of certain syndromes like Fragile X or tuberous sclerosis or whatever. But the networking problem is what causes autism. Where do we put them? You want to put it in front or here?
Anyone wants to try and examine, come. 2 volunteers come forward. Come, we must make an attempt to examine here. We are going to learn a lot. Your neurology will be confident.
Nobody asked, then I have to call you. Come now.
Come, one more.
Your third year? Second year? Are you very good? Then excellent.
Come, one more. Come. Very good.
अच्छा बाई ती काय बोलतं काय आई बोलतं पण तुम्हाला बोलतोय कोणाला बी बोलतं
नाही फक्त माझ्या सासूला बोलते
अच्छा सासूला बोलतं असं आणि तुम्ही विचारलं पंखा कुठे लाईट कुठे
नाही ती एवढं लक्ष नाही देत
ती समज नाही आणि तुम्ही बोलावलं तर हाक मारला की तुझं नाव काय आहे तर नाव त्याचं काय आहे नाव काय आहे?
तिचं नाव मृणाल आहे.
तर मृणाल सांगितलं की तुमचं काही पेट नाम आहे, तू
तिला
बघतो?
मुक्ता म्हणून आम्ही हाक मारतो.
तुमच्याकडे बघतो?
हा बघते ती.
नक्की?
हो, हाक मारले की ती लगेच अशी मान वळवते.
इमिजिएटली?
हा.
ठीक आहे. 10 वेळा बोललो तर 10 वेळा
हा,
बघणार.
10 वेळा बघणार.
सो दॅट इज.
Is she responding to sound or she is responding to name?
Well, that is always a difficult thing, but if for example, if her hearing is normal, you don't have to shout for her to listen. So you call her name, she will respond. So if it happens once out of 10 times, you don't know. But if it happens consistently, to soft calling also, then it's unlikely to be because there is a background noise all the time going on. If you're shouting out the name, Mukta, then she might listen to you.
No, what I mean is you can say, not call her name, say wall. And if she looks, then she is responding to sound. But if you say Mukta, she is responding, she knows the name.
Correct.
Sir, only to sound she'll respond if there is no other sound. But then it will be like the only distraction, so she'll respond.
See, there's always a white noise at the back. See, no, when you, the kid is listening to a lot of sounds, correct? It's only when we listen to a particular tone or a particular voice or whatever that you respond. So anytime a signal which you recognize, which is different from the noise, signal to noise ratio, so that signal has to be to a particular voice or tone. Now, if it happens once in a while, it could be coincidence. But if it happens 10 times out of 10, you have to accept it. So there is a discrepancy, and आणि काही पॉइंटिंग करतं काय असं दाखवते नाही
नाही दाखवत.
What is that pointing? When does that happen? And what milestone is it? Is it social? Is it motor? Is it what?
Pointing out object.
Or is it a combination?
It's a social milestone. Social milestone.
Okay. Anybody else has anything else to say?
Around 1.5 years old.
So it's classified actually as a fine motor milestone.
Okay.
But yeah.
Pointing towards object.
But it's actually non-verbal language. So it's a milestone. Yes, language milestone with a non-verbal. So what do? You're using pointing to communicate. So it's a communication milestone. This is what I want. And usually comes at what age? 12 to 15 months. So here you have a kid who's not pointing, who's not even holding things in her hand, and yet she's speaking. Well, she says that, but we have to accept it, but you have to sort of confirm it when you see it. Actually, you want to just tell us before we wake her up, what are your findings?
So talk about inspection, whatever you can.
Can we? Remove this, huh? Later on, if she wakes up, she may start crying or something. Okay. One of you, please tell us.
Child is examined in the supine position. No,
Just
typical
give us
pose.
positive findings.
What
are the positive findings? Can you see?
His head size is, looks like micro supine.
Excellent. So the first thing is the head size looks a little small. Very good. Besides small, what else is it?
There is
She's got a bit of brachycephaly?
Oh, sorry. Brachycephaly, yes.
Okay, what else is it?
Apart from that, a slightly depressed nasal bridge.
Okay, now the remaining, you think she's
dysmorphic.
dysmorphic or you think she's okay? I mean, grossly dysmorphic or
No,
highly
not
dysmorphic?
grossly.
Everybody who's a little slow, are usually FLKs. You know what FLKs are, no? Funny looking kids. But basically, is it like you think it's a chromosomal problem or do you think it's just a little different?
Not grossly dysmorphic.
Not grossly dysmorphic, okay. And what else do you see?
There is no typical posture.
It's not? Of course there is.
Hypertonic.
So this is the pitted frog posture. Okay, but can you make any judgments on this? I mean, is she hypotonic?
No, obviously no.
How do you know?
Because
This posture occurs in hypotonic children. When you sleep, okay, your tone reduces. But it is very unusual to sleep like this, completely externally rotated. Because there is some tone, and that's why usually the lateral aspect of your foot like this is very difficult. You try and sleep like this. It's difficult. Okay, so this seems to be hypotonia, maybe exaggerated by the fact that she is sleeping. Okay. Everything else seems okay, or
no, obviously.
Nutrition-wise seems fine.
Sorry?
Nutrition, there's no obvious wasting of any muscles.
do you think she is nutritionally okay? Is it?
Okay, as in for her age, no, but there's no.
Achha, so okay for her. Okay, so you're saying that she's for her stature she's okay. So what is her length and height and weight?
Sir, her weight is 7.8 kg, which is less than -3 standard deviation. Length is 79.5, which is also less than -3 standard deviation. Weight for height is between -3 and -2.
So she is actually wasted. So wasting of muscle doesn't mean she's just, and these kind of kids are almost always malnourished because of various reasons, difficulty in feeding and all sorts of things. Okay. Now, can you wake her up? Usko uthao na.
40 centimeter.
Head is 40.
Yes, sir.
Hey. Look at the mom. She looks like a mom.
Toys.
Hello. Come on. You got some water? Unfortunately, we'll have to do that. Hello. Little long forehead, like a acrocephalic or opticephalic, but it's obviously not. Hold on. Oh God, what are you doing? Come on. Okay, why she अब उठाओ ना. तब तक हम बात करते. Now tell me. Till she wakes up, how do you approach developmental delay? उसको उठाओ.
Sir, look for the developmental milestones.
अरे यार तो ठीक है. You now there is developmental delay. So what is the next step in the approach? I mean, what do you want to know in a patient with developmental delay?
Birth history.
What is the reason for doing all the birth history and this history and that history and all that? What are the
neurological examination?
No, all that.
How do you interpret this delay? So in that interpretation, what is the next step now?
You understand? There is a reason why we are doing this. So what are the reasons?
Progressive or regressive or static.
Very good. So you want to know one, whether it's a static problem or whether it's a progressive problem. True?
Whether the patient is trainable, can.
No.
Progressive,
Whether it's
regressive.
a global problem or a specific problem. Correct? And third, what is the etiology of the problem? Correct? You woke her up. Pinch mara kya? Correct? So these are the three questions you have at the beginning. What is causing this? Well, first is it global or is it specific? Is it static or is it progressive? And what is the possible risk factors which have caused this problem? Correct? So now in this case, the first question, is it global or specific?
It's a global.
Global. So in global delays there are lots of etiologies. Suppose it is specific. Suppose this child had predominantly motor delay. Then how would you What would you think? What would be your interpretation?
Cerebral palsy.
Cerebral palsy. So what is cerebral palsy?
It is a damage that is. It is a
Damage कैसा बोल सकते हैं?
static encephalopathy.
No, static encephalopathy is not a diagnosis of cerebral palsy. I mean, patients with mental retardation also have static encephalopathy. So is there a difference, mental retardation and cerebral palsy? Because many people say known case of MRCP. That means he has actually passed the exam, MRCP. But what is the actual MR and CP? Let's clear some concepts over here. So what is CP?
CP is a problem with posture and movement.
So it's a problem of a motor pathway dysfunction. A static, but could change. So static, changing problem of motor pathway, which is in tone, posture, balance, etc. Got in the when?
Before birth till neonatal.
Up to 5 years of age. So child at 2 years gets a meningitis and has spastic quadriplegia. After that you still call it cerebral palsy. And then you have prenatal, perinatal, postnatal. That's okay. Majority are perinatal in our country. Majority are prenatal in foreign countries. So that is different. But CP is only motor. So you may have MR, you may not have MR. There are many brilliant CPs. Patients people who have passed their, done excellent for themselves. So MR is not a natural accompaniment. The MR, what is mental retardation? What is mental retardation? And when do you diagnose it? I'm not asking you for a textbook definition. I'm just asking you for a practical definition.
Based on the comprehension of the person or the intelligence of
social.
Don't get me onto intelligence. I'll take you around the road only. So basically, cognitive functions which are important in social adaptation to life. Correct? So you require cognitive functions for social relationships. You require cognitive functions for schooling. You require cognitive functions for careers. Correct? So adapts. So what you have? Those cognitive functions are many. The attention, there's social, there's visuospatial, mathematical. All these are multiple intelligence. But basically it's mental retardation means everything is affected more or less equally. Okay? So you will have a delay. When do you diagnose it? Would you diagnose it as MR? So after 5. Why do you diagnose it after 5? Because of plasticity. So the brain is very plastic, is malleable in the first 5-6 years of life. And that's why if there's any change which is going to happen, you might have a child. What is the preceding clinical syndrome of mental retardation? Global developmental delay. Okay. So if you do a global development, you have global developmental delay, your risks for getting mentally retarded are much higher. But some children who have delay pick up, catch up. So they are not retarded. That means the global developmental delay has improved. Or other, so you never diagnose mental retardation till 5 years of age and never diagnose CP till 1 year of age. Usually it's perinatal or prenatal. So till 1 year, tone, posture, balance can all change. It's called changing signs of CP, known since the last 50 years. And these things change and they improve with therapy, and by 1 year they are fine. So don't be ambitious and call somebody CP by till at least 1 year to 18 months. Okay, now let's see. What about, suppose the motor is fine, but the language is delayed. What are the possibilities? Anybody else can answer? Okay, autism, fine. Social, language, sometimes mainly language. Hearing abnormality, absolutely. And there's something called specific language impairment. So you have no other features of anything else, only the language is delayed. And these people very often become, it's usually familial, and the main issue later is what?
Learning disorder.
Learning disorder. So learning disorder, we have a dyslexic child, notice at 7-8 years, you ask a history, oh he spoke late. So that's a risk factor for dyslexia. All these learning problems. Hey! Hello! He said come back tomorrow. Now, there's something interesting over there. Suppose this child...
You've gone.
No, it's okay. See, even now, when he's awakened, the tone appears much better. But he's still everted. Hips are everted. So there is a mild hypotonia. Now, is there any spasticity? What are you doing wrong?
Fast movements.
The movement should be fast or slow?
It should be initially slow and then fast.
Why are you doing that way? Half. Why do you do it fast and slow? Why do you do it fast and slow? What do you want to feel? The clasp. This is a clasp knife spasticity. So clasp knife kabhi dekha? You open it, there is a sudden catch and then it opens fast. So initially it's difficult and then. So that should be, that's why you have to move fast. If you move slow, even the most spastic child may appear to have normal tone. Okay, there are other ways of doing it. Which are the muscles which are mostly spastic? Adductors. This is number of times I've done this, but if you want me to repeat, I can do that. Tell me. Adductor. So tell me how you show adductor spasticity. Now he's sleeping, we have to just show it to him. No, karo yaar. Don't give me a lecture. Karo. No, adductor bol rahe hain. How do you demonstrate adductor? So you want to try? No, scissoring fine, but now he's sleeping, so... So you always flex the hip, flex the knee, and do a rapid movement like this. Is there anything? Okay. How do you do hamstring? Because the adductors are tight, spastic, the hamstrings are spastic, the gastrosoleus is spastic, and the last is hip flexors are spastic, especially rectus femoris. So, okay, so you always keep the knee straight and move it fast. Okay, and then hamstrings, popliteal angle. How do you do popliteal angle? So adductors fast, there is no catch at all. Of course, it's possibly also because he's deeply asleep. Second is, you can see the catch? It's not going all the way. There's a catch over here. Let me do it slowly. There's a catch over there anyway. So he's got a bit of spasticity of the hamstrings. Yeah. Catches over here. Catch. Now, if you want to see if it goes all the way, you go slowly. Much more. The catch is over here, but I can go all the way here. Okay, so there is hamstring spasticity. You keep this straight and keep your hand like this and fast. Stops over here. So there is a catch over here. Now suppose I go slowly, you can go all the way. So fast movement, you get the clasp. Slow movement, you can see how much contracture has occurred. So when the fast movement and slow movement are equal, that means it's contracted. That means you can't use Botox. Very good. Of course, I'm not saying I'm going to use Botox over here, but that's the way we decide. You have contracture, you can't use Botox. You know, Botox is used for spasticity. There are other methods of demonstrating. Vertical suspension. So what do you think? Scarf and to hypotonic.
Put the mic here.
Hypotonic. Remember, spasticity and hypotonia are very commonly together. And where is the hypotonia generally? Correct. Truncal muscles. So you're holding them proximal, you may slip out. If you put them forward, they fall forward like this. So hypotonia is mainly axial. Spasticity is mainly appendicular muscles, limb muscles. Okay, in the upper limb, the muscle to check is always the pronator. So this is the pronator supination, because pronator is tight. So you feel a catch when you're doing pronation and supination.
I think it could be a rigidity as well as spasticity.
Correct.
And also hypotonia.
Correct. So one of the causes of hypotonia, for example, is basal ganglia disease. So people have dystonia. What is dystonia?
Abnormal tone, which is it's an abnormal tone, which is
abnormal tone is even spasticity, madam.
Leading to the posturing.
Correct. So twisting movements, which are either intermittent or fixed, and they're twisting movements around the axis of a joint. That's of course, but twisting movements, repetitive, which can lead to postures. Usually postures are, what is this?
Extension.
This is collis, retrocollis. So retrocollis is a very early sign in CP. Unfortunately, we can't demonstrate over here. But in children who are, if you say are 1 month, 2 month old, you do a vertical suspension, the neck tends to go back. And that's an early sign of dystonia. Second, opisthotonus. They're crying, they go backwards like this, arching of the back. That's truncal dystonia. Then sometimes any action, you get twisting movements of the hand, go backwards like this, that is dystonia. Okay? So any action versus dystonia. When you try to do something, it worsens. And the last thing is the leg. You very often get inversion of the foot and plantar flexion, like a talipy equinose position. So again, that could be dystonia. So dystonia is best seen when the child is doing something. And the next thing important in dystonia is overflow movements. So our brain is structured such that you can use your arm or leg very precisely. That means some muscles have to be silent, some muscles have to work. Correct? So if I have, for example, if I am extending my arm like this, if the flexion is also occurring, so the triceps is working, the bicep should be absolutely silent. But if you have concurrent firing in both muscles, you get dystonia. Okay? So for example, I want to pick up this. It's a very precise movement. Exactly there and picking it up. How does CP do it? You see that? That's called overflow movements. So you're trying to, certain muscles should work, but too many muscles are working. And this is the most disabling part of CP. Extremely disabling. Because they're difficult to treat, medications may not necessarily help. And that's why if it's severe dystonia, you may have a normal intelligence inside, but you have a body which is just not working. So, leke jao. Anything else? I think we stop over here. What do you think is the cause over here?
Birth asphyxia.
Okay, birth asphyxia.
And preterm baby.
So let's talk about patterns of CP.
Can we ask them whether this is static, progressive, and...
What do you think it is? Static or progressive? Okay. Now let me tell you, you have a child who at 4 months, 5 months had head control. Say sat at about 7 months, and at 18 months still sitting, and at 24 months still sitting, but no standing and no walking. What would you classify that as? So there is developmental delay, correct? So you have a child, suppose you had seen her at say 7 months, she had a motor age of about 3-4 months, correct? 4 months she was turning, and at suppose you had seen her at 9 months, she was sitting by that time, so she had a motor age of 7 months, 6-7 months, and now you are seeing her at 2 years and she has a motor age of 6-7 months. So what has happened?
So what is happening to the development? How is it progressing?
Is it, you still call it static?
What has happened? There's one word to describe this. Yes?
Arrested development.
So can arrest occur in progressive disorders? So when you have a pen,
there has to be a loss of previously achieved milestones.
1 minute. It depends on when you see them. This is milestones. This is age. This is normal. Okay? This kid, little delayed, then arrests, later regresses. So if you see her over here, she's delayed. If you see her over here, she's arrested. If you see her over here, she's regressed. So just because you do not have regression doesn't mean it's a non-progressive disorder. You have to keep your mind open. Okay? Over here, of course, this is not much of a concern because there's a perinatal issue, you know, you have everything else is fitting in. For example, girls. It's a very common thing which is not recognized. Girls coming with near normal development first 3-4 months, then arrest, and then remains arrested or even slightly goes down, and then loses hand use. Rett syndrome. So developmental arrest should never be taken to static hai, CP hai, chhod do, because you might be missing something. Okay?
So can a progressive disorder achieve milestones? It's a progressive disorder. Can he achieve milestones?
This part is achieving milestones. So initially he is achieving milestones. It's later on it arrests and regresses. The other progressive disorders are, let's see, suppose you are either here or on this line, and then you go down, and then you again come up, and then you're okay, and then bang, and then like this. This is also a progressive disorder. It's not continuously progressive, but over the long term, so there's a stepwise progression. What kind of diseases? Yeah, metabolic sab mein hai na, most of them are metabolic. No. Metabolic and degenerative disorders mean there is a genetic component. It affects development. And there are different organelles which are involved. So you may have storage disease, lysosomal storage, which is usually a progressive downhill. Like for example, metachromatic leukodystrophy or, and neuron steroid lipofusculosis. There is no improvement. It's a downhill process. Then you have metabolic conditions like mitochondrial disorders, where you go down, especially with fever, so disorders of energy metabolism, or disorders of urea cycle, or disorders of fatty acid oxidation. These are encephalopathy, which you go down, then again you start coming up. So the type of developmental, trajectory which you follow helps you decide which group of disorders these kids have.
Can a CP has a motor deterioration?
Anybody?
A CP was walking, now he cannot walk. And you called it a CP.
Correct. So it's, the disorder is static, but there are secondary changes, contractures, deformities. For example, most common deformity, and absolute negligence if you don't pick it up early is hip dislocation, what's called SDH, spastic dislocation of the hip. Initially very mild, easily treated by minor Botox or surgical procedures like a tenotomy or something, and if it is left alone, becomes painful at the age of 10 or 15, and this kid is in severe pain, can't sleep at night, and then if you have to do the surgery, you have to remove the damn head. It's such a major surgery. All because we say CP hai, kuch karne ki zarurat nahi. Okay, so X-ray of the hip has to be done yearly in every child with cerebral palsy. Remember that. Okay.
So, 5 minutes on investigation and management.
Tell us, how will you investigate and how will you manage? So management actually includes investigations and treatment. Unfortunately, we have not been able to examine him, but only on the history.
Management, the diagnosis is...
what is the diagnosis? Yes, what's the diagnosis? We didn't go to the diagnosis.
2.5-year-old female child, a case of hypotonic CP with breakthrough seizures
Would you call hypotonic or would you call mixed CP? You only told me there is spasticity. Correct? Yes. And then if you have CP, what should you tell me? Besides, so when you're saying CP, there has to be one, what type of CP? So hypotonic, spastic, dystonic. The three main ones. Basically spastic and dystonic are 70% or 80% of all CPs. Second is distribution. What is the distribution? Quadriplegic. So you are saying spastic, quadriplegic, mixed cerebral palsy, fine. With
breakthrough seizures.
Okay, why breakthrough? What is breakthrough seizures? What is the meaning of breakthrough? Every word should be analyzed, please. Anybody can tell me? What are breakthrough seizures?
Low anti-epileptic drug level in the blood result in the...
Okay, that's a cause of breakthrough. But what is breakthrough? When do you use the word breakthrough? I mean, the word is obvious. Breakthrough.
In a known case of seizure disorder when they occur.
First of all, don't use the word seizure disorder. Use the word epilepsy. Okay.
A convulsion occurring in a known case of
It's a breakthrough seizure. No. Correct. So you have to be well controlled. So you have a patient who's been controlled for 2-3 years and suddenly gets a seizure. In that the levels may have gone down, the sleep may be less, or they had a febrile illness or whatever, and he had a seizure. That's called a breaking through good control. So if you have a breakthrough seizure in a well controlled, what do? You don't add a second drug. You say wait, sleep little better, all that kind of thing, and wait. If it keeps happening, of course you do a level. If he's on drugs. So basically breakthrough is there. So this patient has never been controlled, no?
But after 2 years, he had one episode of convulsion despite being on antiepileptics.
I'm sorry. 2 years? He's only 2 years old.
2.5 years old.
So when did he start his epilepsy?
At birth, he had...
Oh, that is the question. When did he start epilepsy? What did he have at birth? We had a discussion on this. What did he have at birth?
Actually, she has not witnessed the event.
Forget about witness. I'm telling you he had a seizure. What did he have? Acute symptomatic seizures. It is not epilepsy. When did the epilepsy start? At 2 years. Correct? If there's only one case, we can finish this only. Maybe better. We have a... Shall I write over there? So this is important. There is insult, any insult, meningitis, hemorrhage, hypoglycemia, hypoxia, etc., etc., etc. Latent period, clinical epilepsy. So you had the insult at birth, acute symptomatic seizures. In this latent period, what is happening? Is the brain silent? Everything is fine? No. The process of epileptogenesis has started. Now, when it starts, whether it starts here or whether it starts here, we don't know usually because nobody does. But if you do an EEG in a child who had, say in this child at the age of 1 year, you may have found changes, spikes and sharp waves, suggesting that epileptogenesis has already occurred. Clinical epilepsy may occur later. It may not occur at all, but usually it does occur in these kind of very badly damaged kids. So this, you start anti-epileptics. What are you doing?
Suppressing the activity.
Is it disease modifying or is it symptomatic treatment? Symptomatic treatment. So you can afford to wait if it's a brief seizure, especially if it's a normal child. In a child like this, you probably start treatment. But in a child who's normal, you have one seizure, you may not get another. So why start treatment? But that has to be tempered with a lot of other factors. Where he lives, how crazy his parents are, how anxious they are. There are parents who keep looking. So there are other factors, non-medical factors. You might decide to start treatment. But generally, early epilepsy or new onset epilepsy, especially if the risk of recurrence is not very high, especially in children who are normal, who have normal EEG, who have normal MRI, the risk is about 20%. What is the risk in the normal population? 1%. Correct? So really, and if you give anti-epileptic drugs, what is the risk after anti-epileptic drugs? 10%. So from 20 you are making it 10. Okay, this is worth the giving the medication? No. But then non-medical factors, especially in India, come into play. So that may be different. Suppose you have a patient, first seizure, in somebody who is like this. EEG is terribly abnormal, MRI is abnormal. What is the risk of seizures? 70%. Second seizure. Would you treat? Yes, 70% to 10% makes sense. Okay. So So this is a decision to treat is based basically, do you change the course of epilepsy by giving early treatment? No. There was a very nice study which has shown all this, that two years ke baad, in children with newly diagnosed epilepsy, whether you treatment early or late, after 2 years 70% are seizure free anyway. So it's not disease modifying. So where is the research right now? Here. So this is not anti-epileptic, this is anti-epileptogenic drugs. And unfortunately, anti-epileptogenic drugs, there has been a lot of research, nothing has come about. So if you have a patient who has an insult, and suppose he starts getting he do his EEG every month, and you start showing that he's got epileptic spikes, go ahead and give the drug. Or give the drug anyway from the beginning, and maybe you can stop, but there's nothing as yet which has been found out. So this is what type of epilepsy?
Sir, can we take a few questions from the web?
Sure.
The first question is regarding the graph you drew. Now, when this child is not achieving milestones, say till 2 years of age, do we call him regression? Then how do we call it a static encephalopathy? We are not clear about that.
No, you must understand one thing, that you cannot make a diagnosis always at first contact.
Right.
No. The way you approach the diagnosis is if you have a patient who has an obvious cause, who has other comorbidities which go along with that cause. Say for example, you have a perinatal asphyxia. Then you see the patient, say at the age of 6 months or 8 months. He's got dystonia, he's got spasticity, he appears to be socially not bad, he doesn't appear to have, he's a quadriplegic, he can't use his hands, and he's delayed, so he's delayed in all, but more so in, so you know this is a picture of central hypoxic ischemic encephalopathy. Correct? So you can make a confident diagnosis of this is a patient with a static encephalopathy. Let's take another example. Patient is consanguinity. So there's a higher risk for metabolic disease. You see the patient at 6 months. He's not holding his head very well. Correct? So you don't know. It looks like static encephalopathy. Because he held his head, maybe he's just started sitting, but he's about little couple of months later. This patient, would you call it a static? Well, I'm not sure. I would say follow up. Because there's a risk factor for metabolic disease. Suppose there's no risk factor, he may catch up. So don't use the word static, progressive on the first contact, unless there's a definite, obvious cause. And he fits in the clinical syndrome. So you have perinatal brain injury, most patients will have a motor syndrome. For example, preterms have periventricular leukomalacia, they get spastic diplegia. Kernicterus and HIE have dystonia, therefore the dystonic CP. So all motor symptomatology. If you look at hypoglycemic brain injury, which is also perinatal, usually motor symptomatology is less. So they may have visual symptomatology, they may have hand use problems because they can't see and because of parietal lobe damage, they don't use their hands. Even though there is no spasticity, there is no dystonia. So we call it apraxia of hand use. So visual, apraxia, no dystonia, no spasticity. So all these syndromes which have been there, you can actually think about what is the pathophysiology of these things, looking at where the disease is. So if you have the syndrome, you have an obvious history, it's fine. But if you don't, be careful. Just wait for the second contact.
I thought the small head circumference is in
Absolutely.
favor. If this was a progressive disorder due to any reason, head circumference would have been normal largely. This is a small head circumference, so it has to be prenatal or perinatal.
Correct.
And I think this history therefore suggests that.
The only problem is, in patients who have progressive disorders, who have any disorders, the head circumference at one contact is never really enough. The biggest lacuna of teaching in pediatrics is nobody does the head circumference. Many people just don't do it. Weight and height, everybody concentrates on all that, but nobody does the head circumference. So suppose you have a child, say, who's come at 4 months, and who has a below, or 3 months, who has a below 3rd percentile head circumference, then you're more sure that he's got definitely a static disorder. But suppose you have a child who has Rett syndrome. Now, Rett syndrome is not typically a metabolic, it's a genetic disorder, but it arrests development. So suppose we consider Rett to be a progressive kind of disorder, they may have normal head circumference at 3 months. And then you chart them out at 9 or maybe 1 year, the head is not grown. So you have acquired microcephaly. So if you see the child at 1 year, you may say it's a microcephaly, maybe it's prenatal, but perinatal, but it may not be. So the head circumference you must do every time the child visits you. And you must do the maximum OFC. People always do, certain points and all. Nonsense. Everybody's head is different shape. So whatever is maximum in that particular child is what you need to do. And you have to monitor, you have to put it down in, so that you can chart it.
Yeah, sir, so, what you have given us is a very broad picture for clinical practice. But these clinics are focused on exam going students. So for them, if they have if they have a definite etiology, a small head circumference and a pattern fitting in, they would call it a static encephalopathy.
Absolutely.
Yeah.
I think, Anand, I wonder whether the confusion was for the developmental arrest bit.
No, the confusion was that graph going up, static and then going down.
Correct. So I think the point which sir is making is that when the graph becomes static or developmental arrest, so to say, it could be static but it could be progressive. So wait and decide.
The problem is that the exam going students want to know, abhi kya hai?
In the exam they can't say that, no, I'll wait and watch. They'll say, come after 6 months, we'll see you there. So that's one point. Now the second question which is causing a bit of confusion is, can hypotonia and spasticity exist, and if so, how? What is the physiology? This has been asked 2-3 times, so I thought we should clear it up.
Yeah. See, suppose you take again this may be a general answer, may not help your exam going students, but suppose you have the motor cortex. Okay? And I take a knife and I cut out only the motor cortex. What will happen? Hypotonia and loss of hand use, fine motor use. Correct? Suppose you have that same thing coming lower. The damage is now not in the motor cortex only, or not in the motor cortex at all, but say in the white matter tracts, which contains corticospinal and other motor tracts. Spasticity will result. Okay? Now the same problem, you go to the basal ganglia and you damage the basal ganglia. What are the two things which happens? Hypotonia. Why don't you see dystonia in the first 6 months of life? Because you haven't learned many movements. So dystonia generally in CP comes after 6 months. Before the kids are floppy. Correct? So hypotonia and dystonia. And if you cut off the dystonia with medications, what do the physiotherapists complain about? Both hypotonic ho gaya. Because the damage to the basal ganglia has caused both. The dystonia is more obvious. The hypotonia may not be. Suppose you go to the cerebellum and you damage the cerebellum. What happens to your toe? Hypotonia. So it depends on the pattern of injury. And every pattern of injury is possible in a particular baby. So if you look at generally CP, the majority of patients have a mixed picture. But the most prominent is what is obviously described. So dystonic CPs have severe dystonia, but they also have hypotonia. If you have a picture of a patient with a spastic quadriplegia, they of course have major thing is spasticity. Therefore they are called spastic quadriplegic, spastic. But they also have axial hypotonia. So it depends on, for exam purposes, you only concentrate on what is maximum. So maximum dystonia, you say dystonic, don't say hypotonia, please. Otherwise fail ho jayega. Spastic. But in in
most of our patients there is a nutritional hypotonia.
Yeah, that also is possible.
Which is another problem.
Is it correct to say that if you have profound hypotonia, then the damage is very severe?
Well, hypotonic CPs alone, pure hypotonia, they are rarely caused by perinatal injury. Very often they are there with syndromes, with Prader-Willi syndrome or with Zellweger syndrome, but that's a progressive disorder. I'm talking of static disorders, brain malformations and stuff like that. Usually the term hypotonic CP should never be used, or it is used with extreme caution when language and social milestones are much better or almost normal. Never. Hypotonic CPs have severe retardation. They are like zippo.
Yeah, that's the point I was saying.
If you have a hypotonia severe with normal language and social or near normal, what do you think of? Neuromuscular, benign congenital hypotonia and those kind of conditions.
And you were going to tell us about patterns of cerebral palsy. Since we are doing only one case, could you just tell us what patterns to look for?
Okay, so let's look at like I said, what are the patterns of cerebral palsy? In this case, it's spastic quadriplegia.
Mixed, no, sir.
Okay, no, but predominantly spastic quadriplegia. Correct? So what are the things which can cause spastic quadriplegia? Like we mentioned, this is the brain, the ventricles. Oh, 1 minute. Let me do it over here. Okay, so this is a cut section, axial, of the brain at the level of the frontal horns. Frontal horns, caudate, putamen, thalamus, posterior. Correct? So in patients who have, say, spastic quadriplegia or dystonic spastic quadriplegia, CHIE, the main areas this is inferior, this is little superior. So this is on top, this is a little bottom. The damage is thalamus, putamen, perirolandic. Perirolandic is the Rolandic fissure, which in front has what cortex? Motor cortex. What is behind it? Sensory cortex. I'm just trying to remind you of your anatomy. Of course, this will not help you in your DNB exams. But still, you should, I think, understand this. You don't have any involvement of the grey matter. Very little, except a little bit over here. So what does the motor cortex over here affect? The motor cortex. So you can get legs and arms, quadriplegia. Okay? You also have damage over here. So you have dystonia and a little bit of hypotonia. So you get a dystonic spastic quad with relatively preserved cognitive functions. They can recognize their mom. They can't speak. Why can't they speak? Because of motor. It's an anarthria. They can't speak because they cannot move their muscles and their tongue and everything else. That's why they can't speak. But they have language. That means they have what words and all come to their heads. They can't express them because of the motor problem. So you have this unfortunate situation of dystonia, spasticity, complete can't do anything, and not a bad intelligence, as you would call it. Now let's look at connectors. What is this part? This part is called the... So in connectors, the bilirubin affects what? It affects the globus pallidus, which is the most medial part of the putamen, of the medial to the putamen, the lentiform nucleus. So the most important thing you see in connectors is dystonia, chorea, athetosis. Okay? Again, the cortex in white matter is spared. So you don't see spasticity. You don't see cognitive issues. I told you this story before, but I was in the US. On rounds, we were in this 18-year-old child who had come with, a dystonic cerebral palsy. I mean, he was dyskinetic and all that. And I was a resident, I was discussing with the honorary who was with me, the professor. And I said, he really looks retarded. And suddenly there was a flurry of activity on the typewriter. I don't know how he managed it, but he wrote on the typewriter, I am not retarded. So that taught me a big thing. I was extremely embarrassed. The professor was started laughing outside, but the point is, the child who looks like this completely looks retarded. He's not retarded at all. He had a typewriter and you could type it out, you could understand what I was saying. That's why I'm saying CP and MR are different. They can coexist, like diabetes and hypertension. But they are different. Okay, so connectors is there. And why do you get a problem in hearing? Because it also affects the cochlear nucleus. So I will show that over here. Then we go a little up. This is a little below. And you go to the level of the body of the ventricles. Okay? Now, in preterm infants, what happens? Before we go to this, I will just finish HIE. So the first one, HIE, I showed you is called central HIE, because the main damage is in the center, in the basal ganglia. But there is something called peripheral HIE. So peripheral HIE is mainly in the cortex and white matter. You also may be in the basal ganglia. This causes spastic quadriplegia and complete zero. And if you look at the scans, there are multiple cysts in the brain. All the cortex is destroyed. So why this difference? Anybody can tell me? You have central hypoxic ischemic encephalopathy and you have peripheral hypoxic ischemic encephalopathy, and sometimes obviously a bit of both. Anybody heard of acute total asphyxia? Okay? So you have an abruptio placentae. Everything stops for a few seconds. Either you die, or if you are delivered at that time or whatever and you are resuscitated, you have acute total asphyxia lasting for a few minutes or whatever, You regain your heartbeat, everything is okay. That patient will get central HI. The same patient, if he's got prolonged partial asphyxia, so he has oxygen levels going down, his blood pressure has hypotension but not asystole, that patient will have peripheral HI. Obviously, in practice, you don't get exact division like this. So you get a combination of both. But this is the way you understand HI. The last thing I'll tell you is what happens in preterms. So in preterms, the damage is periventricular leukomalacia. Okay? This white matter year and year is susceptible to hypotension and to infection. So the most common reasons why preterms get PVL is because of sepsis and because of hypotension. And the damage is mainly close to the ventricles. What are the fibers over there? Leg fibers. And that's why you get leg more than arm, and it's called diplegia. And sometimes all the white matter is gone. And you get spastic quadriplegia. What about cognition? They're not bad. The diplegics are absolutely fine. They don't have any problem. I mean, they very often go to normal school also. The quadriplegics are always delayed. They have delayed speech. But they are much better in cognition because the cortex is spared. Because the grey matter is spared. Okay? And finally, hemiplegic CP is usually caused by either a stroke in the MCA or some sort of migration abnormality on one side. These kids usually are normal mentally and they have a hemiplegia. And the earlier the hemiplegia, say prenatally, it improves much more than if it happens at 6 months or a year or whatever. So these are the patterns.
The most ill understood is cerebellar CP.
Most cerebellar CP doesn't exist. So pure ataxic CP, the dictum is try and find a cause. So for example, conditions like ataxia telangiectasia can look like CP because they're very slowly progressive. They have mainly ataxia and stuff like that. There are many other conditions you won't go into, but basically ataxic CP pure, think of something else. Of course, all these other things, for example, connectors may not be severe, maybe just a dyskinetic, chorioathetoid, they have ataxia. But it's not pure ataxia. It's very unusual to be damaged only to the cerebellum.
I think we'll go to another short case. We have a short case. Yeah.
Any questions or all this is very clear? It took too many years to understand this.
Question. Sir, one question. Sir, this cause of spasticity is because of, there is a inhibitory signals which has been cut off because of human lesion. And what is the cause of hypotonia in case of CP? Central hypotonia, we generally use the term. What is the cause of hypotonia for that? Because
no, tone is a very complex thing. It requires excitatory inputs and inhibitory inputs from different parts of the cortex. So if you have a cerebellar disorder, for example, if you have a cerebellar lesion, your tone reduces. If you have a basic, now exactly the mechanism is different in different parts. But amongst the three, hypotonia, dystonia, spasticity, hypotonia is from multiple levels. So is that you're trying to ask me that if I cut the pyramidal and extrapyramidal tracts, you'll get spasticity. The same thing doesn't apply to hypotonia. Because the hypotonia can occur from multiple levels, right from the central to the peripheral. So right from peripheral, it's motor unit downwards. So let's just look at it. Tone is controlled by pyramidal or your motor cortex. It's controlled by basal ganglia is controlled by cerebellum, and depending on the inhibitory excitatory influences, it will be different. And then all that stuff goes to the spinal cord, anterior horn cell, from their nerves, roots, nerves, junctions, neuromuscular junctions, muscle. So the hypotonia can be at any level over there. It's a little complicated to just tell you where is the lesion in hypotonia and why does it exactly occur.
Thank you, Dr. Pallavi. I think Dr. Gautami is presenting the next case.
My patient Kanis Fatima, 9 years girl, third by birth order, born out
That's
of
very good. The first time I've heard somebody say girl and not female child.
Born out of non-consanguineous marriage, hailing from Bhagalpur, Bihar, resident of Kurla, Sheikh by community and Muslim by religion, brought by and informed by mother, with chief complaint of weakness of right side of body as noticed by mother since the age of 2 months, and right-sided focal paroxysmal events since last 1 year. The history dates back to 2 months of age when the baby had developed fever, which was high-grade intermittent, not associated with rigor, temporarily relieved by medication, and baby was active and feeding during the interfebrile periods. The baby was admitted for the same at government hospital and given symptomatic treatment. The baby was started on intravenous medications, following which swelling had developed on the right hand, and at the same time the mother had noticed paucity of movements of right upper limb and right lower limb simultaneously, with the right hand in fisting position, in spite of the decrease in swelling of the right hand. The child was admitted for 7 days following that, but was not investigated for the fever. This episode had no history of any irritability or any altered sensorium, nor any history of any paroxysmal events associated with it, any deviation of angle of mouth or any nasal regurgitation during the feeds, or deviation of eyes, or any history of any involuntary movements. There was no history of any head injury, no history of any fracture or prolonged bleeding or any skin lesions like purpura, no history of cyanosis or any cyanotic spells or diarrhea, vomiting or any oliguria.
I think, how old is the baby?
Now she is 9 years.
If I asked you what happened 9 years ago, would you know these details?
Sir, right.
So what I'm saying is, just give what is, if you ask them, pisab kam kar rahi hai, so nahi. So these things are not something which are observed very easily in a 2-month-old baby. So what I'm saying, just give there was a febrile illness, and the paucity of movements were noted, and the important questions you asked, there was no seizure, no abnormal movements, no lethargy, no unconsciousness, he was feeding well. That's enough. Purpura, oliguria, all these are irrelevant, because even if I get that history, I will not give any credence to it. Just give what is important. There's no history of goes on sometimes too long. I'm not trying to criticize you, I'm just saying that try and just focus on the important part. And then was this.
Since then, the mother had noticed increasing tightness of the right upper limb over the years and right lower limb, but right upper limb tightness was more than right lower limb and the child had developed flexion at the elbow joint and flexion at the wrist joint over the time by approximately 2 years of age. The girl had achieved head holding at 4 months, followed by rolling over at 6 months, could hold objects by left hand by the age of 1 year. The girl could sit with support approximately 2 years of age and walking with support at 4 years of age.
Sorry, she sat at 2 years of age?
Yeah, with support. Started to walk with support at 4 years of age, and the weakness has been improving since last 2 years, in the sense that the child has been opening the fist but still not able to hold objects by the right hand, and can presently straighten the right hand with overhead movement of the right upper limb above the shoulders. She has been walking without support since the age of 6 years, but with difficulty in wearing slippers previously. However, child can presently has no difficulty in standing from squatting position and has no difficulty in wearing slippers presently. There has been history of right-sided focal
So
paroxysmal.
what is mainly affected, arm or leg?
The arm.
Okay. I think what we'll do is a short case, so we'll go through the whole thing. You give us your impressions and then we'll ask you questions.
Sir, since this last 1 year, there has been development of right-sided focal paroxysmal events occurring at a frequency of 2 to 3 times per month. The events lasting each time for 15 minutes, and is associated and is in the form of clonic movements of the right upper limb and the lower limb, and associated with loss of consciousness, the child not responding during the episodes, with staring look of the eyes, and it is preceded by the aura. However, there is no history of any postictal drowsiness during such events, or any deviation of angle of mouth, or any frothing from angle of mouth, or bladder or bowel incontinence. There is no history of any affection of the speech, or any history suggestive of sensory loss, or any involuntary movement, or any squint or facial asymmetry.
Okay. History over?
So, birth history... nothing,
Normal,
sir.
abnormal?
Birth history, she was actually home delivery.
That's still normal.
Yeah, no history of birth trauma. Nothing.
Fine. So at the end of the history, I want to know, 1, what is the clinical syndrome? And number 2, what do you think has happened, caused it? So tell me, what do you think? Give me a diagnosis at the end of the history. Remember, neurology, the examination doesn't give you the diagnosis. It's the history.
Sir, could have been it's maybe it has been since birth, but the mother may not have noticed it, or could have been
What is the diagnosis?
Can be hemiplegic CP or any acute infantile hemiplegia.
So what you are saying is there's a right hemiplegic cerebral palsy.
Yeah.
With?
There is presently there is no cranial nerve involvement, no
No,
contracture.
don't tell me what is not there. What is the next diagnosis?
Acute
Because you haven't told me anything about her school. How is she? School में कैसी है?
Sir, developmental.
कमजोर है. Okay,
So fine motor wise.
No. She's got a hemiplegic CP. We assume she's got a fine motor issue.
Fine motor and.
So when you talk about a diagnosis, you give a diagnosis. Don't give the whole history and all the findings and all. So right hemiplegic cerebral palsy, which you mean that there is a static disorder affecting only the right side of the body. Number 2.
With complex right-sided complex partial seizures.
Would you use the word right-sided complex partial seizures, or would you use the word? See, again the same thing. Seizures and epilepsy. Seizures can be acute symptomatic. You don't think these are acute symptomatic. So this is epilepsy. Because you're getting unprovoked, correct?
Yeah.
Unprovoked seizures, which are right-sided.
Yeah.
So it's focal epilepsy. And what is the cause of this? Is it idiopathic? Is it symptomatic? Is it cryptogenic? So what are the 3 terms? What are idiopathic convulsions? Idiopathic epilepsy?
Cause
not known, mostly genetic epilepsies. Now, by the way, all the classifications are again changing, but we will go to the old classification because that's what your examiners will know. So, idiopathic focal epilepsy, you don't think so?
It can be actually, sir. There is no history of any perinatal insult or anything.
What is perinatal? I just told you that you had a postnatal insult. So, you have a cerebral palsy caused by a postnatal insult. Or it may be a perinatal, or it may be a prenatal insult. We'll talk about that later. So, one is that, can you have an idiopathic epilepsy with a focal deficit?
Yes.
The answer is no. Okay, occasionally, if you have a bad idiopathic epilepsy, you may develop a focal deficit because of the seizures. Like for example, have you heard of Dravet syndrome? So Dravet syndrome, sometimes you have such bad febrile seizures, they go on for hours together, and you may develop a hemiplegia because of the seizures. But primarily there is no focal deficit, and this patient has the focal deficit before the epilepsy, correct? So idiopathic epilepsy cannot have a focal deficit. Usually doesn't have developmental delay, but may have, but definitely no focal deficit. So this is not idiopathic epilepsy. And remember, idiopathic epilepsies, we call them usually genetic. Second, is it symptomatic? Yes. Symptomatic means there is a cause, there is an abnormal lesion which is causing this epilepsy. So what are the types? Acute symptomatic, you think it's acute symptomatic, or you think it's remote symptomatic?
Remote symptomatic.
So what is remote symptomatic?
Can be due to any previous insult which has
Correct,
happened.
correct. So, you remember I told you that? Oh, it's gone. Insult, epilepsy. Insult occurred at 1 month of life, according to your history, but a little
2 months.
Come to that, 2 months, whatever. And the epilepsy started at
9 years.
9 years.
8 years.
So from whatever, early life to 9 years was a period of epileptogenesis. That's called the latent period. So this is remote symptomatic focal epilepsy. Remote symptomatic focal epilepsy. This child right now is saying right hemiplegic cerebral palsy, remote symptomatic focal epilepsy. The third diagnosis.
Can be acute infantile hemiplegia.
Acute infantile hemiplegia is given rise to. If the syndrome of acute infantile hemiplegia is diagnosed when the child develops the hemiplegia. You don't diagnose it later on. She's got a persistent deficit, na? She may have had an acute infantile hemiplegia, a stroke or whatever, but she's got a persistent deficit. Now it is she's got a static motor deficit of the right hand and leg. Correct? Which means that this is CP, cerebral palsy. Don't call it acute infantile hemiplegia. Acute infantile hemiplegia is the acute syndrome.
When you would have seen this baby at 2 months, you would have called it acute infantile hemiplegia.
You won't have called it.
And now sir is asking what is the next component of the diagnosis?
The third component. So one is a comorbid condition. You have a hemiplegic CP. You have a comorbid condition of remote symptomatic focal epilepsy, which is related to the hemiplegic CP. And the third is, she just told you. Sorry?
Any cognitive.
So how do you call it? Learning disability or learning disorder. It may be because of retardation, it may be because of learning disorder, it may be because of attention problems, whatever it is, there are learning issues. 3 things. Now, what is the point against what she's saying? When do you notice the deficit in hemiplegic CP?
There will be handedness, early handedness of the.
So when do you notice it?
Below less than 1 year before.
Over here. So do you notice hemiplegic CP at 2 months?
She started.
I'm asking you, do you notice the hemiplegia at 2 months? Do you notice the hemiplegia at birth?
Can be. Due to birth trauma, it can be.
So if you have a history that this child had decreased movements of the right hand at birth, what is the most likely diagnosis?
Birth trauma like Erb's palsy.
Erb's palsy or brachial plexus or brachial plexopathy, not hemiplegia. So when do you notice hemiplegia? When you start using the hand, which is after the age of 5 to 6 months. 2 months, which baby is going to use the hand? It's very odd to notice hemiplegia at 2 months. There might be a mild paucity of movements. I think over here what happened was the IV went out and that poor IV owner is being blamed for the whole life. This is the problem. You don't notice hemiplegia. That's why most hemiplegics occur when? What is the most common cause of hemiplegia? I just told you.
Any insult, any
Insult? No, I just told you, no?
stroke.
Stroke, infarct. So when does the infarct occur in most hemiplegics?
Any prothrombotic state. Post
When timing?
Does it occur?
Perinatal age.
No, prenatal. Perinatal, yes, but before birth. That means I'm assuming perinatal is 28 weeks to 1 week after birth. Right? So, usually strokes which cause hemiplegic CPs are in the perinatal but not in the neonatal period. If they occur in the neonatal period, what do they usually present with? Seizures. So seizures, neonatal seizures come with neonatal, most common presentation of neonatal strokes. Everything gets okay, he's fine, baby's gone home, 6 months later the parent says, ये right hand use नहीं कर रहा है. So you notice the hemiplegia which occurred at birth, which is neonatal stroke, which is very much only 30% or 20% and 70% are before birth. Okay? So I think that's what it is. Now let's see the findings.
Could a asymmetric Moro would have picked up? Would there be asymmetric Moro at that time?
Yeah, of course. If you're examining a baby, you might pick it up because there might be fisting and all that. But remember, at 2 months of age, even fisting is normal. And asymmetric Moros is like, you have to be a great clinician, and the poor mother is not that. And you're basing your diagnosis on the mother's history, not somebody who examined him at that time. Come. तेरा नाम क्या?
कनिष्ठ फातिमा.
तो कहाँ रहती है?
बंटर वन के पास.
अच्छा. What is the mental status examination?
Fine. Social and
Give me what you've done for the mental status examination.
कुल्ले में रहती हूँ.
She can say 10 to 20 word sentences right now, cannot narrate stories. She cannot perform mathematical calculations. Otherwise...
She cannot narrate stories?
No.
बेंजी, वो बोलती नहीं आपको क्या हुआ स्कूल में? स्कूल में क्या हुआ? मैं आज गई, हैप्पी बर्थडे था. कुछ नहीं बोलती है. तू स्कूल में जाती है? स्कूल में तेरा फ्रेंड कौन है?
किसी से दोस्ती नहीं करती.
आप एक काम करेंगे, 2 मिनट इनसे बात करने दो. हाँ? अच्छा बोल, तू स्कूल में क्या खेलती है?
कुछ भी.
कुछ बोल ना, क्या बोल? एक तो चीज बता. ये पकड़. बोल. तू स्कूल में छुपा छुपी खेलती है? तो छुपा छुपी कैसे खेलते हैं?
भागा भागी.
भागा भागी में क्या करते हैं?
खेलते हैं.
अच्छा, छुपा छुपी मालूम है तेरे को? क्या छुपा छुपी में क्या करते हैं?
खेलते हैं.
ओके, ठीक है. ये I'm just examining the mental status because obviously she is not 9-year-old level. ये कलर कौन सा है? हरा है. देखना बराबर देखना, ये क्या है? ये
हरा कलर का.
हरा. अच्छा, और ये फूल लाल कलर का. और ये
सफेद.
ये सफेद है कि कुछ और है?
सफेद है.
अच्छा, ठीक है. तू लड़की है कि लड़का है?
लड़की.
अच्छा, और डैडी?
अब्बा
है, लेकिन अब्बा क्या है, लड़के की लड़के?
लड़के
हैं. और मैं क्या हूँ?
डॉक्टर.
अच्छा, ठीक है. मेरे को बता, तू बड़ी कि मम्मी बड़ी?
बहन बड़ी है.
हाँ, बहन तो बड़ी है, लेकिन तू बड़ी है कि मम्मी बड़ी है?
बहन.
तेरे में और मम्मी में कौन बड़ा, दोनों में से?
So knowing of opposites, 4 years, most kids will know. बोलना, तू छोटी है कि मम्मी छोटी है?
छोटू मैं हूँ.
ठीक है. So she seems to know. She's getting a little confused, but I think she knows. 3 एनिमल्स यानी कि जो जंगल में रहते हैं ना जानवर, उनका नाम बता. 3 जंगल के जानवर. बोलना, बोलना बच्चों. मैं तेरे को हेल्प करता हूं. एक बहुत बड़ा है, बड़ी सूंड है. किसको है वो? कौन है?
नहीं मालूम.
अच्छा, 3 जानवर का नाम तो बता. कोई भी जानवर. एनिमल मालूम है तेरे को? जानवर बोलना.
नहीं मालूम.
नहीं मालूम. ठीक है. हफ्ते में एक दिन का नाम मालूम है? बोलना. रविवार, फिर
मंडे.
मंडे, फिर
संडे.
नहीं, मंडे के बाद क्या आता है?
मंगल.
मंगल, फिर
बुध.
बुध, फिर
शनिवार.
शनिवार आ गया. बना उसके पीछे क्या है? सो वीक्स, डेज ऑफ द वीक, ऑल दिस इज नॉट necessarily because of retardation or something, maybe also because of exposure and stuff like that. So let's see something else. Can she draw?
She can draw a triangle.
अच्छा, टॉयलेट सुसु पोटे का कभी मालूम पड़ा उसको?
पेशाब का अपने से करती है.
नहीं नहीं, वो तो अभी, लेकिन मालूम कभी पड़ा?
5-6 साल के बाद वो बोलने लगी हो.
5-6 साल के बाद?
नहीं तो अपने से वो करते, हम लोग साफ करते थे.
नहीं नहीं, ऐसा नहीं. लेकिन चड्डी में कभी नहीं कर, बंद किया करने को?
4-5 साल के बाद बंद किए.
Very important history, because this is an important social milestone which if you don't achieve is usually children who are intellectually handicapped. The other thing which you see, which might also explain the intellectual handicap, is what?
Sculpture and the microcephaly.
Microcephaly, absolutely. Okay, then you make her draw. What should she draw at this age? Okay, I will just tell you. 3 years,
Circle.
4 years,
Square.
5 years,
Triangle.
6 years.
Hexagon.
Okay, well, diamond is 7, but you that I don't know how to call it. This is, you should do this, by the way. It's very, very 6 to 6.5 years you do this. In 7 years, 8 years, there are other shapes and these things. या कि करेगी? नहीं करेगी? अच्छा, ठीक है. So that's, by 9 years you should do a cylinder also. I don't know what she can do. So she seems to be intellectually handicapped. Okay? Now what are the findings on the other examinations? Cranial nerves?
Cranial nerves were normal.
Normal?
Yes.
What do you expect in a hemiplegia?
Facial.
She doesn't have?
No. No facial asymmetry.
Yeah. Absolutely nothing. So where is the lesion? What's happened to that facial? It should have been there, no? Anybody can tell me? Why is there no facial? Face has bilateral innervation, but if a Buddha gets a stroke, he gets a facial which remains, no? So when do you have a hemiplegia without a facial? Timing bolo. When do you get a hemiplegia without a facial? Congenital hemiplegia. So remember, the face is innervated. The lower part of the face is unilateral. The upper part is bilateral. But that is bilateral before birth and at birth. Before birth really is bilateral. So if you have a congenital hemiplegia, you won't have a facial. Of course, she may have had a facial which recovered. That's also possible. But this suggests that she may have been congenital. All other cranial nerves are normal?
Yeah.
Huh?
Yes, sir.
What other cranial what are the cranial nerve would be abnormal in this?
Sixth nerve not affected.
Why you think it's a brainstem stroke? When you have a sixth nerve and hemiplegia, that would not be in the. You think it's cerebrum or it's brainstem or what?
Cerebrum.
Cerebrum. So how can it be sixth nerve? Anybody? Rahul? Third and fourth be in. Where is the lesion? Lot of confusion. Okay, shall we do it later? I'll just examine and then. Okay, I'll just finish it. So, motor cortex, corticospinal tract in the, what is the white matter above the ventricles? This is the coronal view. Capsule, going into the brainstem, midbrain, pons, midbrain are here, pons is here, medulla decussates and goes to the opposite side and goes down to the lateral corticospinal. Correct? So if you have a lesion over here or here, you get what she has. Suppose you have a lesion in the capsule, what else will she have besides the hemiplegia? Sensory, yeah, but sensory is difficult to test.
The dense hemiplegia.
Field cut. Got it? So field cut. You didn't check for field, did you?
Vision I check.
Vision has nothing to do with field. What is field? Side vision. Let's see if we can get somebody who's. ये काम करेगी? चलो कुछ नहीं करें. Can you see? यहाँ ही देखा. You have to give him space. आप पकड़ो ना. इसके बाजू में पकड़ो. कौन सा हाथ हिल रहा है? ऐसा नहीं, यहाँ ही देखिए. कौन सा हिल रहा है? कौन सा हिल रहा है? यहाँ ही देख. कौन सा हिल रहा है? कौन सा हिल रहा है? You saw that? And I'm moving both. यहाँ देख. कौन सा हिल रहा है? दोनों नहीं हिल रहा है? नहीं. So she's got a right field cut. So cranial nerves are not normal, no? Now tell me the findings in the arm. Show me. Show me, no? Utro. Before, I'm sorry, I forgot this. We didn't complete this. So if you have a hemiplegia in the midbrain, what else will be affected? Third. Correct? If you have a hemiplegia in the pons, what will be affected? Sixth and seventh. So ipsilateral, third nerve in the midbrain with contralateral hemiplegia, ipsilateral, sixth or seventh with contralateral hemiplegia. So when you say third, fourth and all that, that means you've gone to the brainstem. Okay, she doesn't have any obvious third or fourth or sixth in her case. So it's above that. Okay, now tell me what is more involved.
So the posture of the limb, right upper limb.
वहाँ जाओ. यहाँ चलो ना. चप्पल के बिना. चल. This is the problem is. जाओ. चलो. Chalo, give somebody else. Maybe you can say. So what do you see? Tell me whatever you see. Give her the mic. Chalo, chalte jao. Come on, I'm waiting. Can we do one thing? Can we go tight pants pehne here? Chalo, she might get upset if you take it out. So what is the first thing you notice? Is it possible to focus on her feet? What is the first thing you notice? 1 minute. 1 minute. So first let's concentrate on her lower limbs. Tell me, what do you see? Joe. So the heel first gate on the left. There's a slightly everted foot on the right. Not slightly. Hell of a lot everted. Joe. And there's a little hint of toe walking on the right. But it's all very subtle. Okay? अभी लंगड़ी कर. नहीं होगा? ये पैर भी नहीं होगा. अच्छा, एक पैर पे खड़ी हो जाएगी. मैं पकड़ूंगा ना तेरे को. वो हाथ दे तेरा. खड़ी हो जा.
पे खड़ी हो. एक पांव पे खड़ी हो. वेरी
गुड. अभी ये छोड़ेंगे तो तू 2 मिनट, 1 ही मिनट छोड़ दे उसको. वेरी गुड. देख तेरे को मालूम.
वेरी गुड.
अभी राइट फुट कर.
अभी दूसरे पांव पे खड़ी हो, वो वाले पांव पे. वेरी गुड.
छोड़ो. नहीं, राइट फुट
वो पांव पे खड़ी हो, वो पांव पे. हाँ,
छोड़ो. You see that? So difficulty in standing on the right foot and virtually impossible to hop on it. So the earliest, one of the best ways to demonstrate a mild motor deficit is to make a hop. Okay? That's one. Second thing is, anything else you notice? Yes, size. Very good. So the right foot is smaller. Turn karo. Ask her to concentrate on the feet. No. Woi baju ghum yaar. Can you see the feet? No, like this. This is the camera, no? You can see there's a light eversion. The arch is fallen on the right side, and there is a shortening or smaller foot on the right side. Which means what? Where else can you see it? 1 minute. Where else can you see it over here? Upper limb. So let's see where you see it. Can you see the nails? Nails दिखते हैं क्या? It's clearly small. Look. If you look at, everybody can see it later, but the whole hand is small. So what does that mean? Hemiatrophy. What is the conclusion?
Disuse atrophy.
No, this is not disuse. You don't get disuse atrophy in adults. So this is because of, it's an old lesion. Remember, the parietal lobe is very important for growth of the limb. So if it is damaged early in life, then your growth is arrested. Or not arrested, but reduced. And therefore you get hemiatrophy. So what you can surmise by this, even if you did not have the history, this is very early onset hemiplegia. Okay? I mean, let's see the hand. Chalo, what do you see? What are the things you look for? The position?
There's lots of swinging movement.
Very good. So automatic movements are not there on the right. And what else? So automatic movements are not there. Chalte hi ja. Well, her position of the arm is like this. Now why is it like this? See? It's a little abducted at the shoulder. It's pronated. It's flexed at the elbow. And the wrist is flexed. Why?
Anti-gravity muscles.
No. Don't use all those confusing terms. Anti-gravity, is confusing because we're people who walk on 2 legs. So what is the muscles which are more spastic? Speak on the mic.
Flexors in the upper arm.
So biceps. Then
Supine, pronator.
Pronator. Very good. Wrist flexors. And spastic. Okay, and the last?
Finger flex.
Where's the finger? Is it inside? Hath dikha? Yeah, it's cortical thumb. Okay. So in this, now you have to check with the contracture you said, no? Hold it. So contracture is not there. Okay. So you should do it slow if you're looking for contracture. So spasticity. The catch, there is no contracture. So catch is here, and then I can move it fully. Catch is here, but I can move it fully. Catch is here, but I can move it fully. So there is no contraction. Okay? So what is the only thing, where is the problem? Is it arm, leg, what? What is more? ऐसे करेगी? करना ये हाथ से नहीं होता है ये हाथ में ले ले. So what does she have? Almost a little bit of palmar grasping, but not even that. So significantly disabled upper limb. While lower limb she's okay. She's got a mild limp and all that, but nothing much. So this is brachial more than crural hemiparesis, which usually means which territory? MCA, correct. So MCA territory is usually arm more than leg, facio-brachial paresis. And what is anterior cerebral? Crural paresis. Much rarer, and therefore you don't see it much in kids. And sometimes you have a dense paresis, like you have a deep infarct or something. ठीक है bija. She's upset, I think. Anything else you want to?
Could we have demonstrated the field cut?
Well, it may not be a cut. It may be visual inattention, or in the sense she is neglecting the right side. So it's very difficult to be sure.
Otherwise, we throw the light from one side.
Light is not very helpful.
And then you don't see it when it is lateral, and you come medial and the light reflex is present.
In infants, it's difficult. So what you do is double fixation. Then you take this pen. You take this. Has to be something without no rattling. You show this, which is the less attractive, and he looks at it, and then you bring this forward, and he looks at this. The same thing you do on this side. So he looks at it, and then he looks at this. So fields are okay. But if he does it consistently on one side only, and doesn't do it on the other side, then he's got a temporal field cut. Now we never examine nasal field cut, we look at temporal field cut. And we assume it's homonymous, which is also a big assumption, but so now, have you changed your diagnosis after examining her? Have you?
Cranial nerve involvement.
Yeah, no, but so only thing you added is that visual inattention. Otherwise, your history has given you the whole diagnosis. That's the point I'm trying to make. So spend 90% on the history and 10% to confirm what you already suspect. Any questions?
Yeah. There is one comment to be made. So if there are no questions from the audience, we can wind up the clinic. Are we winding up? Okay. So there was one question which came on the net about which textbook to read or which website to go to learn on this issue. So the message I want to give the person who asked this question is that you read any book, but what you have seen today is a mesmerizing amalgamation of knowledge which has been applied on a day-to-day basis. So I would only suggest that you keep watching this. Thank you so much for such a lovely clinic.
Thank you. Thank you.
We would also want to announce our next clinic, which is going to be on next Friday, the 28th of August, at 4 p.m. from Kalavati Sion Hospital, New Delhi. Thank you for watching this broadcast.